Conversation cannot be overstated. If you see the global disaster database, which says that we have at around 393 disasters all over the world, with around affected 167 million people, with economic losses of around $250 billion. And India, unfortunately, is one of the 10 disaster-prone countries, one of the 10 most disaster-prone countries in the world. We are simultaneously facing floods, we are facing cyclones, landslides, cloudbursts, so many natural disasters and public health emergencies. Recently also, I think in Chennai, Manali town, we had a cloudburst. I think we all remember it. These disasters disrupt livelihoods and put a tremendous pressure on our health system. In such a context, our health system is the front line of defense, not only during emergencies, but before and during and after it. I invite our panelists to share their insights, grounded in evidence and their vast experience, how India and maybe the global community can build a resilient health system capable of withstanding the shocks of disaster and of the extreme weather events. Let me warmly welcome our first speaker, Dr. Akash sir. I would like him to give a perspective on the National Program for Climate Change and Human Health in the context of our disaster and extreme weather events. Welcome, sir.
Good morning, everyone. To begin with, at the outset, I would like to give my special thanks to the Director of Public Health of the state of Tamil Nadu and also to all officials of this directorate for organizing this wonderful DIFICON and the efforts that they have taken to strengthen their public health systems, and to which this DIFICON I believe contributes immensely. The topic that I'm going to talk about is climate change driven extreme weather events and public health preparedness, the perspective of the National Program on Climate Change and Human Health, which is a new program 5 years ago started under the National Health Mission for the Ministry of Health and Family Welfare. Climate change is a phenomenon to which most of you would by now be familiar, but my attention that I seek for all of you is to go to this round figure on this side. If you look at that circle, you will see how the drivers of climate change in their turn tend to impact a number of series of exposures, and then in turn all of these exposures would lead to a number of health phenomena. In today's talk, my focus will be only on the top three that you see: the extreme heat, the severe weather, and the air pollution. The purpose for drawing attention to these three is the extreme manifestations of these three phenomena in recent time in the world, also including India, is taking a toll of human lives and also to the health of our public. In climate change extreme weather events, the drivers are not only environmental drivers, the more important ones are also anthropogenic and drivers. That means that we as human beings are also responsible to a large extent for why all this is happening. We may not be able to do for what's happening in the environment on its own by the way of nature, but at least we can do our role by ensuring that we minimize the anthropogenic contributions. If you look at this figure out here of the World Health Organization, you would like to understand that the health risk from the climate change is largely because of a cluster of three group of factors. what we call as the vulnerability factors, the climate-related hazards, and the exposure factors. A mix of all this eventually decides the risk for a country, the risk for the state, or the risk for the district. Of these, there is also a huge contribution to adaptive factors which are included within the vulnerability factors, and the only way we can help from our end is to ensure that we increase the substance of adaptive factors so that we are able to counter the impact of other factors and eventually be able to reduce the risk that we have from climate change on our health. But what's important is when you go down to the section of health outcomes, you see, look at the spectrum of the health outcomes that the climate change has, beginning from injury and mortality to heat-related illness, to respiratory illness, to waterborne diseases, to water-related health impact, to zoonosis, to vector-borne diseases, to malnutrition and food-borne diseases, to non-communicable diseases, to mental and psychosocial health. Please understand that there is no spectrum of human health which is spared by the impact of climate change. I've just tried to give some of the examples on the side of the statistics that are true for India. Now to the same figure, if you go a bit more right after health outcomes, another impact is how it impacts the health systems and facilities. It not only impacts the human health, but it also impacts the healthcare deliveries and the health system through which we try to help our people. And if you look at the numbers that I have given around, it also as how the healthcare infrastructure and health systems are impacted by climate change related impacts. So what are we doing about it? Globally, there have been certain declarations by which pathways have been shown to the countries that how they can work towards climate change. India became signatory to the Maldives Declaration in 2017, in which certain national level commitments were listed. Also, in 2023, the World Health Organization, CRO, put in place an operational framework for climate resilient health system, which also provides what national level commitments can be done. If you look at what these commitments are, briefly, it's about having a strong leadership and governance, a climate smart health workforce, working towards climate health risks and greenhouse gas emissions assessment, integrated risk monitoring and early warning systems, climate resilient low carbon infrastructure technology and supplies, climate informed programs, emergency preparedness, climate health research, and climate health financing. Now all of that component is what any country, any state, any district needs to do if it has to work towards becoming climate resilient. India started a struggle in 2015 when the Prime Minister's Council on Climate Change proposed that there should be a separate mission for health, the health mission. And the road journey started in 2015, went up to a program being inducted under the Ministry of Health as a national program on climate change and human health. In 2019 under NHM, we had our first national action plan in 2019, followed by a thematic area-wise action plans. In 2021, we had integrated digital surveillance systems integrating climatic component and health by 22-23. By 2024, all states were able to develop independently their state action plans on climate change and human health, including the state of Tamil Nadu, which were released none other by the Honorable Prime Minister himself in the month of October 2024. And now we are advancing toward development of district level action plans on climate change and human health. I'm glad to know that the state of Tamil Nadu's all districts have been able to make substantial achievement in putting up their district level action plan. So what are the main objectives of the program? They are all same aligned to what I showed you about what we had commitment from the WHO framework and from the Maldives Declaration. We also work on the 5 pillars. The first pillar is awareness advocacy. The second is climate smart health workforce. The third is strengthening health sector preparedness. That are governance and climate informed programs and climate health research. So what was the state action plan, why they were needed, and what are the district action plans? The state action plans are action-oriented guidance developed by the state government themselves, which identifies their priorities and their resource allocation. The health is led by the health-led multi-sectoral task force, wherein sectors of all others relating to health, be it water, be it environment, all of them are brought together to discuss where health is on the charge. The document that was developed was for the year 2022 to 2027, and after it's over, we'll go on to a 2.0 version of State Action Plan, which will have far more thematic areas included. The current thematic areas in the State Action Plan are about the heat health plan, the air pollution health plan, the extreme weather event and health plan, and the sustainable climate resilient healthcare facility plan. But we would also go forward in the next 2.0 to have specific zoonotic diseases, vector-borne diseases, mental health, NCDs, etc. Now, when we come to the district action plan, again, the levels have been reduced up to the district because within the same states you would have different climate scenarios for different districts. So each district should be able to develop its own action plan. The most important part is that these plans are also supposed to be integrated into the mainstream plans. There is a state action plan on climate change that the Ministry of Climate Change developed. So the SAP-CCHH or the DAP-CCHH gets integrated into the main plans that the Ministry of Climate Change developed. The heat health action plans get integrated into heat action plans that the NDMAs and the SDMAs develop. The extreme weather event health plans get integrated into the SDMPs and the DDMPs that are developed by, again, the state disaster management and the revenue authorities of the states and the district. So I'm not going to speak about what we are doing in heat. Most importantly, the activities are what I've listed up here are there, but I just want to bring an attention. Please understand our understanding on heat is very important. It is a new subject. Many of the officers or clinical people in your state would be hesitant in diagnosing a heat-related stroke case or a heat-related affected case or a heat-related death. It is a purely clinical diagnosis. We do not have lab tests or autopsy findings that are needed to confirm a heat-related case or a heat-related death. They may be supportive, but they are not confirmative. It's purely a clinical diagnosis. The clinicians, the medical officers, should be trained and should be able to diagnose with full conviction that it is a heat-related death or a heat-related case. Now, it's not only the heat stroke that is an important phenomena that you need to understand, but a lot of cardiovascular deaths that happen during summers are also precipitated because of the impact that heat has on the patient who already have a weak heart. Right. But many important points in there are work that we are working towards heat is developing a heat stroke management unit. You can see a picture from Ram Manohar Lohia Hospital from Delhi, putting in place such management unit, at least in all secondary units in your districts, is to help give the attention to the heat-related sickness in the first 30 minutes of the heat stroke, which is a critical period to save the lives of these patients by immersion cooling technique. Next is air pollution. Again, a lot of work that we are doing in the program in air pollution, but I need to bring to attention to you all, if there are 60 million deaths that happen attributed, 60 million total deaths in the globe, then every year 7 million of those 60 is attributed to air pollution. That is close to 10 to 15% of the deaths, of the total deaths that happen in this world is attributed to air pollution alone. And air pollution right now ranks at the topmost risk factor attributing to death and to NCDs. Please mind it, it's going far ahead of all other risk factors we have ever known. So it's high time to sensitize the medical community and make them understand, and the clinicians to get together and work on that. Right, so the next one is about extreme weather events and health. I know all of the states for a long time have been working on extreme weather events and disasters, so there is not much to do, but what is important is to have a preparedness system, and we therefore, beyond what we usually do, have put in place a tool for assessment of your healthcare facilities and assessment of your district health system on emergency, on extreme weather events preparedness. Please use these tools and try to ensure that your health facilities and your districts are upgraded as per the requirements of protocols internationally sought under this program. Last is the green and the climate resilient healthcare system. There are two components. One is green, that is being a sustainable healthcare facility, and the second is climate resilient, that is to be able to withstand the impact of extreme weather event. Again, our work related to energy efficiency and water efficiency are being worked under sustainable systems, but we also want you to work towards a climate resilient healthcare facilities to ensure that the impacts of heat, floods, cyclones, etc. can be withstood by these health facilities that have been developed by retrofitting or those that you are developing new. We already have under the Indian Public Health Standards put in so that the new facilities will comply to these these principles. Right, so these are some of the work that's going on in the country related to strengthening the health sector preparedness in green and climate resilience. And what's important is also putting together collaborative efforts. What we see at the national level, we have brought together many ministries and many programs together. We also expect the states to also bring together through the work that they have at the state. Please understand, in the state level, there is a multi-sectoral task force and a governing body that overlooks the program to provide a platform for a multi-sectoral approach to handling extreme weather events, handling climate change, and also at the district level, we have provision for a task force. So whether sort of a multi-sectoral working and networking is necessary towards it. I hope you've been able to meet within the timeline of 10 minutes. Thank you.
Thank you, sir. Next, I call upon Dr. Syama, Associate Director at Swasti NGO. Madam, you can give us some concept regarding vulnerable populations in disasters and how we can use technology in disasters and extreme weather events, and why does it matter whether recovery and resilience matters in disaster or we are only interested in relief.
Sure. Thank you so much, Dr. Nirmal. I'm sorry. Hello. Is this better? Thank you so much, Dr. Nirmal, for the questions. I don't have a presentation, so I'm largely going to speak about what we did, especially taking a leaf from our response to COVID. So you asked, how do we ensure equity in disaster response and preparedness? We have seen that disasters deepen inequities because response often reach those who are easiest to access, right? Unless resilience building focuses on women, urban poor, migrants, farmers, fisher folks and factory workers who are hit the hardest and have least access to response measures, I think we risk rebuilding systems that leave the same people behind. Intentional partnerships with community collectives and associations is what ensured that the very people most at risk became active partners with us in resilience building. In our response to disasters, we tried to work with community groups and associations who reflected the voices of communities most appropriately so we could customize what we were doing for them. By institutionalizing community engagement as part of disaster preparedness plans, communities became co-designers. They were not just passive participants, which promoted ownership and accountability, and they built it with us, right? And I think going forward, equity must be a design principle. It should not be an afterthought. Probably we make equity, like a financing and accountability criteria. It cannot and should not be just a value statement. I would actually take this opportunity to sort of make a call for action that funders and governments should warrant evidence that demonstrates interventions closed, not widened gaps. I'll move on to the next one. So that is about how we used vulnerable populations to, or how they were part of the resilience building with us, right? Now, I'd like to discuss about what is the role of technology and innovations in building resilience. System innovations in public health to continue providing services to those who need it the most is what ensured that we came out on the winning side in our battle with COVID, right? And I want to highlight that the most important innovation during that time was collaboration. To address a problem of that scale and magnitude, it was humanly impossible for any of us to do what we were doing by ourselves, right? So we came together through the Community Action Collab, erstwhile COVID Action Collaborative, with about 373 plus partners. We saw how collaboration enabled equity to move communities from relief to recovery to resilience. It helped us pool resources, act faster, reach wider, and build health systems that are shock-proof and future-ready. The collab successfully demonstrated its capabilities by delivering 25 million services to 15 million individuals across India as part of the COVID response. I want to say that this was made possible with the help of technology. I'm not saying that technology is the silver bullet, but technology is definitely the most important enabler, and it definitely is a multiplier that amplifies the effect of everything that we do. A couple of examples that I want to take is that we managed to deliver comprehensive primary healthcare services through digital innovations like telecare models, which made sure that care was never disrupted for those who needed it the most, right? By integrating multiple solutions like healthcare, access to social protection, emotional well-being, etc. on a single platform, we could ensure resilience building was comprehensive, not episodical or fragmented. Another significant potential of technology that we have always known but realized much more during disaster was that how it effectively addresses the challenge of data silos. By leveraging data from multiple sources, we created interoperable systems at the intersection of multiple departments that enabled coordinated action on the ground. But I also want to point out that technology only works when it is designed for equity, right? Simple, accessible, and linked to frontline action that creates impact, lasting impact on the last mile populations. Otherwise, it simply risks widening gaps further instead of bridging them. I want to take this example of how we worked, private sector actors, government, and everybody came together during COVID. We used wastewater testing to estimate and predict the outbreak of COVID through platforms like Precision Health, where we leverage GIS and predictive modeling techniques that help stakeholders have a lead time for planning and focused disease management strategies. One thing I want to highlight here is that we managed to include both formal and informal drainage networks in its sampling focus, which helped to represent underserved and marginalized populations and also provided a holistic picture of disease scale at wider level. Since then, the approach has been expanded to multiple other streams like maternal health, anemia, communicable diseases outbreaks, heat resilience, and so on and so forth. So, what is the role of recovery and why does it matter when it seems like relief is the most important currency, right? So, I just want to start by saying that resilience is not something you deliver, it's something you create. It's an experience, right? It is not an isolated event, it's a journey, a continuum from rapid relief to recovery and finally to systems that can withstand future shocks. While relief saves lives, recovery restores dignity. It is important to rebuild essential services, livelihoods, and psychosocial support so that communities are not just surviving, but they are regaining stability and they are becoming resilient. And I think that is what resilience means, right? It means ensuring continuity of essential services and it brings communities out of crisis to continuity and ensures well-being. Having said all of that, it's very important that resilience is also localized. Preparedness has to begin at the community level. To ensure resilience building empowers the most vulnerable, where we equip communities with the right set of tools, knowledge, and networks to participate, anticipate, and respond to crisis. I want to close by saying that resilience systems should be measured not only in infrastructure, but in terms of how communities experience it. Using people-centric metrics like healthy days gained or unhealthy days reduced will help us determine the true measure of resilience. Thank you.
Thank you, madam. Next, we will have Mr. Harikumar, Regional Coordinator. And to him, I just have a few questions. What is the meaning of resilience in health, in the health facilities or hospitals? And what is the role of government or public health authorities in coordination and governance?
Thank you so much, Doctor. Good afternoon, everyone. I was hoping to say good morning, but now it is already afternoon. And this is really a great opportunity which has been provided by the sir sitting in front and all of you. Wonderful opportunity. And I was very, very happy to see the theme of this year's event is resilient public health system. Resilience is not something which we hear often when we talk about health facilities, and I'm glad that Tamil Nadu is doing this. I was so happy to hear that this event happens every year and that this year's theme is on resilience. And thank you for the question, sir. I'll talk a little bit about Thank you. So, in my segment, I'll be talking more about keeping health facilities functional rather than safe. Resilience is not just safe hospitals. Resilience should go beyond safe hospitals. Because many a time we think of, safe hospitals and there is a delay. Yeah, that's okay. Safe hospitals may ensure, safe buildings may ensure safe hospitals, and safe hospitals may ensure that whoever is in that hospital building during an event, a disastrous event like a cyclone or a flood or an earthquake, may be safe. May be safe. I'm saying maybe. But will that help the people who have been affected by the flood or the cyclone? That may not be enough. This is an example of a safe hospital in an extreme weather event. Do you think this is useful for the community? Can we take in the patients who are affected by this event? This is not enough. Is this enough? This is from the Japan tsunami, and it looks like this hospital is the last building standing. That is how we expect health facilities to be. Looks like it is the last building standing, but when you go closer, you see a different picture altogether. That is, they had considered, you can see the figure 2.8 meter. They thought that the tsunami which will affect them will be 2.8 meter tsunami. The one that actually came, somebody had messed up with the figures, and the tsunami which actually hit them was 13 meters. So all their effort they had put up, because they thought it was be 2.8, they had put their generator on the first floor. All critical utilities were on the first floor. But everything was dashed away because the tsunami which hit them was 13 meters. So you need to understand the risk. I'm told that there are several PWD engineers here, and when you look at sites, you should be able to understand what kind of risks are we going to face in the lifetime of the hospital which I am creating. This is one such case from Sikkim. You see the primary health center of Chungtang was hit by a rock coming down from the hill during the Sikkim earthquake. I am not interested in the rock which hit the PHC. I am more interested in the rock which is outside, the old rock. So the engineer who went to the site to set up the PHC there would have seen this rock, and he should have thought, where did this come from? It came from up there, up the hill. And the brothers and sisters of this rock are up there still, waiting for the next monsoon or the next earthquake for it to come down. So this is not a good site for my PhD. That is something that seems to be common sense, but unfortunately, many a time we don't use our common sense. This is a hospital in Chennai, affected in the 2015 floods. Hardly less than 100 meters from the river. The engineer or the architect or whoever it is decided that the basement is a good place for our electrical panels, for our generators. Was that decision good? Because that is the first place which will flood. We are not understanding our risks, and that costs lives. People died because of that decision. 18 people died here, including little babies. And we don't want, as administrators, as engineers, we don't want blood on our hands. We should really be understanding what all can happen where we are having our facilities. This is from Chile, a hospital built earthquake resistant. You see the building, not even a crack on it. The engineer has done its job, but the false ceiling was not earthquake resistant. The fire sprinkler system was not earthquake resistant. Can we treat patients here? No. You had to evacuate the hospital. Imagine in a wind event or an earthquake, one tile from your false ceiling comes down in your OT. There goes your sterile surroundings. So we need to think beyond the safety of the building. We need to think about continued functionality. How do we ensure continued functionality? What are the factors that cater to the continued functionality? And climate change is reality. You look at, you open the TV any day, you see Uttarakhand, you see Punjab, you see Kashmir, you see Himachal, and tomorrow you may see Tamil Nadu. We have already seen Tamil Nadu many times, but we need to really be looking forward to what all can affect us. Climate change will bring floods, landslides, the spread of vector-borne diseases, heat waves. Sir already spoke about the heat waves and what NCDC is doing. But when we talk about health sector preparedness, we sometimes tend to focus on the building, but not keeping it functional. And there are several factors which have to work together for a hospital to remain resilient, to remain functional. Only one is the building. The other is the preparedness of the staff members. Just imagine, normally you have 300 patients coming in, and in the event of a cyclone, that may go up to 1,000. Is your staff members ready to deal with this mass casualty event? It's part of their preparedness. And if they have to be ready, their equipments have to be functional as well. And if the equipment has to be functional, you need the utility supplies, utility supply systems. Utility systems are electricity, water supply, your medical gases. They all have to be functional. If you need to run your autoclave, you need electricity, you need water supply. And if they are not functional, you may have a good system, you may have staff prepared, but you are not going to help anyone. Your communications have to work. Your medical supplies have to be enough during an emergency to cater to the mass casualties coming in. And your access. We saw a hospital which has become an island in the flood. We have to have access. And this is the component of a health facility. And if all our health facilities can remain functional, that will make a resilient health infrastructure system. That is what we are looking at. Mobile clinics and all may help in the short term, but really what we need to look at is long term, the system preparedness, system resilience. That is what we should look at. And infrastructure, building the infrastructure well is important, but we also need to look at what kind of logistics are required. We have to go beyond the hospital. One thing COVID for everyone. Almost every hospital now has its own capacity to make oxygen. Oxygen plants were given. But what is happening is some smaller hospitals, they don't need to run the oxygen plants now because they don't need that much of oxygen. So they have shut that down and they are still buying oxygen from local suppliers. I've seen, I don't know about Tamil Nadu, but I've seen the rest of the country, that is what is happening. And when an emergency strikes, it is the resilience of that supplier that matters. The road access from that supplier to your health facility, that also matters. The logistics matters. And it is not just a one sector issue. And we understand that now many sectors have to work together. It is a team effort. It is not just the health department. We need the PWD to working along with the water supply department to be working along with us, the power department to be working along with us. It is going to be a team effort, and the state disaster management authority as well. And putting together all of this, it takes time. It is not something we can achieve in the short term. Resilience is not achieved in the short term. It takes time. And the pathways to resilience will be long-term planning. You need to make a long-term plan on how we can get all our health facilities resilient and to remain functional. And it will take a sustained effort. It will also require long-term vision, long-term effort, sustained investments, capacity building, continued capacity building, and policy commitment. This is required I'm taking the example of Tamil Nadu. If Tamil Nadu has to have a resilient health system, then there has to be these. We cannot be achieved in a few months or years. Have we done this before? Has any program had these kind of long-term planning, long-term vision, long-term effort? Whenever we talk in the disaster risk mitigation field, when we talk about a successful program, I have to come to the health sector. The only example, the best example of a long-term risk reduction happened in the country is the Pulse Polio campaign. We had to do it many times. Was it a short-term effort? No. It needed long-term planning. It needed vision. It needed continuous capacity building and a long-term commitment. And that is what we need to do when we are talking about resilience of our health facilities. It's not built in a day, but every step we take, but it has to be taken in a planned way, builds the safety and health of generations to come. Let us invest now so that our health facilities are prepared for tomorrow's disastrous events. And for our engineers, I say, we should not build our tomorrow's infrastructure based on yesterday's information. We should be looking forward to what all can happen in my city, in my town, what all can affect my hospital or PHC in the future. And it's everyone's job. It is not, I'm talking about engineers, but it is not just the engineer's job. It's everybody's job. Disaster risk reduction is everyone's job. When I see this picture, I often remember talking to the health sector. It's like this man, he has to draw the line on the side of the road. There was a branch on the way. Moving that branch is not my job. He painted around it. You cannot paint around disasters. You have to get down and move it. You have to. It is our job. So all of us, let us commit together. This is a great occasion that we can commit together for resilience building. Thank you so much. Thank you, sir.
Thank you, sir. A picture says 1,000 words. Huh? So, thank you for that picture. Right. Next, I will call upon Dr. Sendil Kumar, and we will be kindly give us some insights regarding how medical education institutions' role is in disaster risk reduction, and how we can take forward human resources and training also.
Good afternoon, respected Director of Public Health. Thank you so much for the opportunity, sir. and also respected panelists and respected dignitaries on the dais and off the dais. Once again, good afternoon. And thank you so much for the questions, like being educational institution. So I would like to give just 5 minutes talk. Anybody talk about the educational institution? What is the importance of education institution related to disaster risk mitigation or disaster risk reduction? And I would like to say, like, Tamil Nadu government is doing extraordinary job. And how many of you know about this Tamil Nadu State Institute Rural Panchayat, that is TNSIR, adopting a villages, signing a MOU with the educational institutions, and doing the wonderful job to finding the local sustainable development goals, LS, that is a sustainable development goals, like identifying the villages, identifying the group, and working on the local villages improvement. For an example, being a Vinayaka Mission Research Foundation, like we developed a model village across nearby our institution, like Harikumar and Veerapandi. What we are doing is, like we signed the MOU with the Tamil Nadu State Institute Rural Panchayat. Anganwadi workers and health workers, health inspectors and the PAs in every, so everybody concentrate towards the health beneficiaries. And once a disaster comes, like we need to know, we need to identify the risk in the community, within the community, not outside the community. Most of the people like ASHA or Anganwadi workers, they'll go and see what is the vulnerable population, vulnerable group. But in terms of the community, in terms of risk involved in the community, the best person to know is the local people. So we need to involve the local people. So what we are doing is we need to identify the community person, we need to identify the volunteer, and what we have developed is Youth Disaster Preparedness Committee, that we have developed on a club called Youth Disaster Preparedness Club, where it involves the youth club person, that's an area Kendra Sangathan person, and also the Anganwadi workers, and also the ASHA and our public health professionals. And combined together, we conduct a lot of mock drills for the public. What are the vulnerable population, vulnerabilities there in the community? We are developing it. We are doing the plans also based on that. And also, we need to create awareness. So awareness, we do the regular training to the volunteers, health workers, and also panchayat members in rescue, first aid, and safe water practices, and wash, as rightly said by the previous speakers. Wash also should be taken care. And in terms of crisis, the main focus is information, because information spreads faster than the disaster itself. So what people hear and how they hear it makes all difference. So our humble suggestion is, we need to ensure the message reach people in their own language through channels they trust, be it in posters, mobile alerts, and local media and village meeting. At the same time, our health facilities need to be ready with backup medicine, water, and power. Preparedness at the facility, clarity in communication, build in trust, and trust save lives. So preparedness becomes practical when broken down into small and clear responsibilities. Each village can form simple task forces, one for early warning, one for communication, one for rescue, one for first aid, one for water and sanitation. These teams ensure no household is left behind. Sustaining this requires more than just plans. It needs regular reviews, involvement of schools and women group, and weaving of preparedness into the everyday culture of the village. And I would like to mention about the lesson from the Odisha model. And Odisha has shown what true community readiness look like. In Kanjam district, tsunami ready villages had volunteers on every street who knew which families needed help and how to move them safely. Through strong mock drills, youth groups like Apta Mitra, they developed the Apta Mitra, like we are developed here as a disaster preparedness committee, and consolidated efforts across health and disaster agencies. Odisha has saved countless lives. Their story remains not only for everyone, it's all the states should have a disaster preparedness, and also educational institution to stress about disaster management. So what we did, we have asked all our students to get into this National Disaster Institute of Management, that's NDAM. We have asked the students to go, take up modules and complete the modules, and most of our students, the paramedical students, are having a certificate from National Institute of Disaster Management. And also we are talking, giving a awareness session about this Sendai framework for disaster risk reduction. Sendai framework for disaster risk reduction 2015 to 2030 talks about the Sendai framework, talks about priorities, 4 priorities. The priority 1 is understanding the disaster risk. This involves assessing and sharing information on vulnerabilities, exposure and hazard characteristics. Priority 2 is strengthening disaster risk governance. Good governance at national and local levels is crucial for effective disaster risk management. The priority 3 talks about investing in disaster risk reduction. Public and private investment in both structural and non-structural measures is essential for resilience. And priority 4, enhancing disaster preparedness. This includes improving early warning systems, planning for effective response, and rebuilding more resiliently in the aftermath of disaster. And also, we focus on the targets. The targets talks about substantially reduce disaster mortality rate, substantially reduce number of affected people, and reduce the disaster economic crisis, substantially reduces disaster damage, substantially increase the number of volunteers, substantially enhance the international cooperation, and also substantially increase the availability and access to multi-hazard early warning systems. So, and when you talk about human resource and training, human resource are the backbone of preparedness. No disaster plan can succeed without a well-trained, motivated and resilient workforce. Healthcare workers from doctors and nurses to paramedics, technicians and community volunteers must be trained not only in routine manner and also in emergency response skills. So, we have a team called Psychological Preparedness and Mental Health, and where we work on closely work on this community volunteers, and we are periodically doing the awareness session onto these volunteers. And to conclude, health system preparedness for disaster on extreme weather events is not an option but is a necessity. It is about safeguarding lives, protecting equity and building resilience. Disaster risk reduction strategies provide the structural shield, while human resources and training breathe life to our preparedness. At VMRF, we have embraced this responsibility through our emergency care programs, mock drills, public health outreach, and population safety initiative and psychological first aid training. We have instilled preparedness not just as knowledge but also practice. Let us remember, disaster may be inevitable, but their health consequences must not be catastrophic. If preparedness is integrated into every layer of our health system, policy, practice, and people, we can ensure that communities are not only able to survive disasters, but to recover stronger and more resilient than before. Thank you.
So, is there any questions from the audience to the panelists?
So my question is to Dr. Harikumar. The question is, you explained very well with nice pictures about how the system, the infrastructure should be also resilient to meet. You explained, OT, if the false ceiling collapses, then even that is an important point. It's not the mere structure, even in interiors, how it could matter in a disaster. Now, one area I find a big gap in this infrastructure thing is, in spite of many disasters happening time and again, we still find we have certain mundane or a routine system happening in the country, because state governments operate through PWD and PWDs will put up the structure. Most of the situations, that will be the truth. Has anything gone into this important gap or a gray area in the health infrastructure, which we are still missing out very badly, and which we should do? And what is that most important thing which is not called for till now? That's my question to you.
Thank you so much, sir. It's a very, very important question. The state PWDs, it varies across the country. The way our building codes are written, the building codes which guide all our constructions is only meant for life safety. Life safety only. I am talking about functionality, which is several steps ahead. So you follow the code, your building will be safe. It will not be affected by natural hazards like cyclones or flood. You cannot save because the PWD has to decide on what levels to keep. But health facilities, especially very critical buildings inside health facilities. Not all health, in a hospital there may be 10 buildings, not all are critical. The critical buildings are the ones which give the critical services. So the National Disaster Management Authority has brought out the hospital safety guidelines, and they have recommended that we need to go beyond the code for health facilities, for critical health facilities. And they have also recommended, this is still remaining a recommendation, they have recommended that health facilities need a different code, because the way you build a school and the way you build a hospital should not be the same. In an emergency, I don't want the school to be functional tomorrow, but I want my hospital 5 minutes from that emergency. So these should not be built the same. So there should be different codes for it. But for minimum, every state PWD, I believe, is following the building code, and our building codes are good. They have been proved correct all over again in several disasters. But the basic tenet is that they, what they guarantee is life safety, not functionality. I hope I answered that question somewhat. Thank you, sir. One second, one more.
So from the perspective of the program, I tried to highlight something on my slides. Now health facilities, the program suggests would be some that have already been built, and there would be health facilities that would be built in times to come. For the health facilities which are going to be built in times to come, the Indian Public Health Standards have now been revised. So the Indian Public Health Standard will now comply to the principles of sustainability and also to resilience. So it will be important for any new health facility that comes up to follow those principles whenever they are built. It will provide for ensuring that all the necessary codes that exist at that period of time in the national and the state government will be complied to ensure the safety. For the buildings that already exist, we've also in the program provided checklists and opportunities for the state and the district government to go for assessment of their existing health facilities. Based on the score that you get, you are able to identify and understand, using those checklists and tools, how safe your health facility is in terms of sustainability and also in terms of resilience. And then based on that, you can seek funds under the program and elsewhere to ensure that you know the needful retrofitting if possible to change and make it a better structure.
Yes, sir.
Sir, thank you, sir. Thank you for all the speakers, because from different perspectives we are able to perceive what is resilience, particularly from the institutional perspective, from the building perspective, etc. I am just saying in a lighter vein that the only creation with resilience, forget about the lifespan, is human being. Because Harikumar sir was telling we were very tired of answering the delegates and the people who were questioning the theme, why you have put resilience. Now you have given a different perspective, it is continued functionality. Now we can confidently tell what is resilience. So thanks for highlighting the thing. From all we are talking about the resilient mechanisms, which is a current need. And also now we are not supposed to plan for today, and we are supposed to plan for the future generation. That is what we imbibe from the speakers. Thank you, sir. On behalf of all the participants, I am complimenting you, sir. Thank you. Thank you very much.
Good afternoon, sir. Sir, my question is towards Harikumar, sir. Sir, can you please tell some of the challenges that you faced during this type of disaster management from your personal experience?
The challenges challenges are everywhere, sir. The challenges is what I have been showing also. In a post-disaster scenario, I'm talking about post-disaster scenario, I think the first challenge is how quickly can someone do the assessments and certify that the hospital is safe for someone to go back in and work. Because we need to give the confidence to the doctors and the nurses that it is safe to go back in. And we really have not built that cadre of engineers who have been trained in doing rapid assessments in post-earthquake or post-disaster scenarios. And there are so many examples where the building was good. There were only a few cracks on the walls, which actually was not dangerous at all. But when a doctor looks at it, when a patient looks at it, it looks very, very alarming. So somebody has to give them that confidence and say, this is safe, it's only a plaster crack. So first challenge I often feel is that many hospitals operate outside even though the building is good enough. That is one thing. And also the other challenge which I have mentioned is long-term planning. People cannot, I'm talking generally, no one thinks beyond 5 years. Because 5 years is my tenure. I think maximum is 5 years. And resilience doesn't come in 5 years. Sir talked about Orissa, and I am thinking Odisha in 1999 when the cyclone happened, the 10,000 people died. 10,000 is the number we are guessing because we don't know how many people died. And after 13 years of intense effort by Orissa State Disaster Management Authority, and the cyclone fell in hits 2013, the number of deaths is 22. From 10,000 to 22 does not happen by chance. 4 lakh people do not get evacuated without proper planning. You go to the communities and you ask about their disaster management plan. Even a child will tell me, oh, that is my cyclone shelter, and if I go there, I will be on the first floor and I will get poha in the morning. They know the menu also. That is the level of preparedness. But it took time. 13 years is too short, but we don't think beyond in long term. That is, I think, one challenge we have all been facing. I'm sure all of us will have some challenges to talk about. Would you like to add something, sir?
when you talk about disaster, you can know, you can speak about this COVID-19 itself, like no. So managing the COVID-19, nobody knows what is the COVID and how to manage the things. Like we need to trust the process. One. Number two is like no, you need to believe like during this COVID-19 in our hospital actually like no, you won't believe the youth, that is paramedical staffs and students, they are the frontiers of COVID-19 rather than doctors, because they are the first responders and they only responded very well and managed well, because nobody knows what is that virus and how it reacts and everything. But we need to trust the process, and we were able to manage, and I think Tamil Nadu managed very well.
I have two words to add to it. In the way our country is built up, the disasters and the planning and the response, both of them are led by the disaster management authorities. The disaster management authorities are usually the revenue authorities. Now the point is, when a disaster strikes, it has got two major impacts. An impact on the revenue, the economy. It also has an impact on the health. There are two major impacts, and the lead is always of the revenue department. What I'm trying to emphasize is, I know that in India for a very long time, all state health departments, specifically health departments like that of Tamil Nadu and other states, have played a wonderful role in working against disaster. But in the way that the thing is designed, the health is always kept at a second step, beyond revenue. It's high time that we have to appropriately ensure that the human losses are less. In that case, the health has to come in the front, not only as a player in the whole game, but as one that actually leads the preparedness role. So health is a very important component of how disaster happens. And when I go across the various states to see how the preparedness plans have been developed by the revenue department, somehow or the other, the contribution or the role that they have assigned to health is only of the supportive role, which is very unfortunate. Whereas health should be on the forefront, leading the leadership, because health is one of the most important damage that happens after any disaster that happens. So that change of focus is probably going to be a very important requirement, which all states which have strong leadership to try to afford to make a change. Thank you.
Because of lack of time, and as requested by the organizers, I think we will close this panel discussion with just one comment from Dr. Sendil.
Actually, that previously sir has asked about the building code, actually to Harikumar sir. I would like to mention about IIM Ahmedabad. When the Gujarat, this earthquake has come, so the IIM Ahmedabad build a sustainable building where they build a larger structure. Even if the earthquake comes, it won't collapse. It won't give a much massive destruction. That building, sustainable buildings, they developed after the earthquake. Probably if you are able to see, you can visit the IIM Ahmedabad website. You can find it, the sustainable buildings.
Okay, sir. Thank you. Thank you.
Thank you, sir.
Sir, one last thing. Because Akash sir brought up that point about health, I think this is something probably all of us recognizes, but since we have a multitude of stakeholders, I just want to table this for everybody's thinking. I think one major challenge that we have experienced and we have seen that others have always brought forth is multi-sectoral coordination, or the lack of that, right? Because health is important for sure, but then with a disaster, livelihoods get disrupted. With that comes economic insecurity. So, see, the person on the ground who is actually facing the brunt of it, how do they go to the hospital? How do they make sure that they have the right kind of resources to get to the hospital? They have to run pillar to post to make sure that they are even able to step out of their homes, right? So their priorities are different. We can sit here and think that this is what is important to me, that is what is important to me. But then, which is why I was saying that unless we make all sort of responses people-centric, I think we are going to always face one or other challenge.
Thank you. Thank you, our esteemed panelists and participants, for the engaging and insightful discussion. I just want to say a few points which I think everybody, the main priorities which they have said. One is regarding Dr. Akash Srivatsa's 10% of deaths are mainly due to air pollution. And the preparedness checklist which has already been prepared by the national program which can be utilized. Dr. Syama she has given an insight regarding the vulnerable population and how we can involve the community for it, community level resilience and the continuum of care. Dr. Hari has said one is regarding the site of the health facilities. Usually I have seen the sites of health facilities is the end of the village, near the lakes, near the cremation grounds. These are usually the sites. So that is the one important thing. And then continued functionalities of those health facilities. I think that is very important. Not only the site, but the continued functionalities. Dr. Sendil Kumar had given us regarding the youth disasters preparedness clubs which can be formed in the communities. So that is one important, and then Apna Mitra also has been informed. So thank you all of you for the key takeaways, and we must shift from reactive responses to proactive preparedness. 3 or 4 years ago, we had a good discussion, panel discussion about rabies, which was thought about that time, and after that the whole country is talking about rabies only. And after this panel discussion, I think for another 3 or 4 years, I wish that this topic will be talked about throughout the country. And on behalf of the organizers, I thank our panelists for their valuable insights and all of you for your active participation. Thank you all.
Thank you. Thank you all speakers for sharing your valuable insights. Now we cordially invite our additional DPH and key organizing secretary, DPH Icon 2025, Dr. P. Sambat sir, to honor our speaker, Dr. Akash Srivatsava sir, Additional Director, NCDC. To moderator, Dr. Nirmal Jo, sir, Senior Regional Director, Regional Office, Health and Family Welfare. Mr. Harikumar, sir, Regional Coordinator, South Asia, Geohazards International. Dr. B. Sendil Kumar, sir, Dean, Allied Health Sciences and Head Transformation, Vinayaka Mission Research Foundation. Dr. Syama B. Syam, Associate Director at Swasti NGO. Thank you, sir.
I hope your sugars have not